Hi, everyone. Welcome to the Cleft Palate Craniofacial Journal's video and audio podcast. I'm Pat Chibbaro. I am happy to be the podcast host, and I am really happy to talk with two of the authors of a really interesting paper. And I think for anyone that's been, involved in craniofacial surgery for even for a short time, but for me for many years, just the challenge of the cranial vault surgery and just looking at different challenges that families face and that teams face. So this is a great article that appeared on OnlineFirst on June 17th, and I'll make it really easy for you. When you go on the journal and you go to OnlineFirst, go to page 3, and this paper is in the middle of that. So I always like to tell people where it is because it takes a while to find it. But this article is Socioeconomic Influence on Surgical Management and Outcomes in Patients with Craniosynostosis, a Systematic Review. And the authors are Melanie Bakovic, Liliana Starsiak, Spencer Bennett, Ryan McCaffrey, Esperanza Mantilla Rivas, Monica Manrique, Gary Rogers, and Albert O. And I am really happy to have two of the authors here, Melanie and my friend Al O. Thank you both for being here. And Melanie, a special thanks because she got up at 5:30 in the morning to do this. So thank you.
Thank you for having us.
Yeah, it's a real pleasure. Thanks again, Pat. It's great to see you.
Absolutely. So I wonder, Melanie, if you could, I always like to ask the authors this first, is what made you and your group want to take a look at this issue?
Sure thing. So I think honestly, there's been a recent surge of interest in understanding socio-demographic effect on like treatment and outcomes in healthcare lately. And that's personally something that I was interested in as well. And when I was learning more about craniosynostosis and reading up the literature in this population, I really found that there wasn't really a good comprehensive review of all the socioeconomic factors that might impact care. And I did find a lot of articles that talked about race and how that impacted their care, but race is only like one component of socio-demographic factors. And I think that's kind of what motivated us to want to see what was out there when in regards of other variables, socioeconomic variables such as income, like employment rate, other things that may not be encompassed by just race. And so that's why we went and did this systematic review.
Yeah, to
So
Melanie's credit,
yeah,
she actually came to me with this idea. And so I was intrigued by it because, obviously as a craniofacial surgeon, I see these disparities in my own practice here in Washington, D.C. But, it's no one, as Melanie said, had done a comprehensive review on a real national level. And so
right.
kudos to Melanie for coming up with this idea and really finishing it in a very efficient manner and getting it done, presented, and published quickly.
Yay,
Thank
Melanie.
you.
You got kudos from the great Dr. O. So
Thank you,
excellent.
Dr. O.
It was, when you read, well, maybe you can, tell us, give us a little overview of, but the kind of paper, this takes a lot of work. You read a lot of paper. So I was like, it yielded 724 different articles. I mean, go for it. Let's hear, give us a bit of an overview, and then we can go a little bit more in depth about it.
Sure thing. So, yes, we wanted to make sure the search terms we used on the different databases was encompassing of all the articles that we might want to include. And so we basically kept the criteria pretty open and just included any articles that had mentioned craniosynostosis management, care, outcomes, and then had mentioned any variables, socioeconomic proxy variables, such as like insurance, as I mentioned, income, hospital type, zip code. And we just sifted through. We started with 724 articles and ended up with 13. So we did have to sift through quite a few. But in the end, it was amazing to think that from those 700 articles, there were only 13 that actually fit all these criteria.
Yeah, Al, the only thing I was thinking is how far back did how far back did those articles how many years back? Because I guess one of the questions is I'm trying to think how long has endoscopic surgery been a big part of like also endoscopic I know is not something I wonder even now that if every team offers. Isn't it, I have seen that there are some patients that have come to me that have said that, well, this team doesn't do endoscopic surgery. Is that, where's that at? I was just wondering because I have been out of the field for a little bit.
Yeah, so minimally invasive or strip craniectomy types of procedures were actually the first ones that were done way back in the day, in like the 19th century. But because the patients died and the correction was that never worked, it was quickly abandoned. And then back in the 1980s in Boston, they started doing them again, but then adding on helmet therapy, which was then started in Texas. And so it's been around now for a good 30, 40 years. And, our study, we wanted to look not just at endoscopic, but any other forms of kind of minimally invasive therapies, which, need to be offered at a relatively early age compared to the open procedures, which most of us do at a slightly older age, because all the results in studies have shown that the long-term outcomes seem to be a little bit more stable if you wait a little longer to do it. And so I think that was one of the things that we wanted to really look into was, did socioeconomic factors play into a role of surgery type? And by surgery type, it really had to do with age of referral and access to medical care.
Right, exactly. So Melanie, yeah, let's talk about those. So of those papers, there were specific things that you looked at. So I wonder if we can just sort of take a look at at each one. And it's going through my paper, which I I'm still a good student, do my highlighting. And I'm old school where I print out the paper. So
I do too.
So, I can't just do it off the computer. I'm just old school. So you talked about a type of procedure, complications, delay. Maybe you can walk us through a little bit about what you found in each of those areas.
Yeah, so I think some of the interesting overarching findings that we had was that most of the studies used insurance type as the main socioeconomic proxy variable. And then when looking at the outcomes, most of the studies actually looked at craniosynostosis intervention. And that, in other words, that means kind of what procedure they did and then at what age or what time they did the procedure, rather than the more strictly outcome variables. So there was limited information on complications, length of hospital stay, hospital costs, and child development. So the main focus was very much on what was the intervention and at what time, as we had just talked about.
Let's talk a little bit about the referral delay. So, in those papers, did it go into detail about why these kids are so? I always wonder, why can't we get all kids referred at an early age? That is, certainly the question. And so, is it that kids of lower socioeconomic status are they seen? Are they what is the reason for you're just wondering. Don't know if you really got a full sense of like really trying to drill down, what is it that's happening that we're not getting, that group of kids? Is it where they're going and they're not getting that, that's not being picked up right away? Or are the parents not, realizing that something might be off? What is it? Why are these kids say they're being seen by a primary care provider who often picks this up? And even kids of lower socioeconomic status, they go to see a pediatrician, don't they? And why is that not being? I guess I don't know. It's just something that's sort of bothered me over the years. Is what is that block to getting those particular kids to see us sooner?
Yeah, and then
Yeah.
Pat, I just wanted to point out, I think your microphone, like when Melanie and I are talking, and it goes back to your microphone for about the
Right.
first 10 seconds or so, it's really, no one can hear you. And it's almost like your microphone it's like trying to pick you up and eventually get started. So I don't know if that's going to affect the podcast at all, but just so that you're aware of that.
Yeah. So can you hear me right now?
Mm-hmm.
So you said it's when it comes back to me.
Right. And so when, like, for example, if Melanie was talking for, 15, 20 seconds, and then you started going on to your next question, at least for me, Melanie, I don't know, was it the same for you? The first 5 to 10 seconds of Pat's microphone, it was really, really faint. And so I just don't know if it's going to affect the podcast.
Is that happening right now?
No, right now it's actually working.
Okay, that's really strange.
I think it might have been when you're kind of leaning back.
Oh, well, let me make sure I sit up straight like the nuns taught me in school. All right, so now it's better?
Yes.
Yes.
All right, Al, thank you. You fixed my problem. See, you're a techno guy. So, so, I just wonder, Al, what you thought. I mean, you've been doing this for a while. It just always bothered me to try to get to, and, I remember my social worker and I talking about this what is this block? What is this delay? Is it that the families get referred, but they don't have the wherewithal to get to us, or are we not, what do you think it is?
Right. No, and that's a great question with no easy answer. I mean, certainly as far as our study is concerned, the focus was, it was unable to look at causality of why we've had the findings that we found. But I think it's very much a multifactorial problem. I think all the things that you just mentioned, which could include, parents perhaps not getting as much regular care for their children as with the, if you think about it, a lot of the kids that we see that are coming from a lower socioeconomic status, they have to come by buses, they have to come by subway. Parents are oftentimes working jobs that are not remote friendly. And so for them to make an effort to come and see a doctor, it's different from, the person who lives in the suburbs with 3 cars and has a babysitter and all that kind of stuff. So, I think, there's a lot of things. There's the home situation, the doctors, as many studies have shown, is that particularly with the push with managed care, these poor pediatricians are seeing, 50, 60 patients a day. And, they're trying to catch, things like heart murmurs as well as, ear infections. And then head shape is something that just may not be on their radar. So, I think that plays a role as well. And then getting the referrals a lot of times with the under or uninsured patients, getting a referral to see a specialist is also more of an issue as opposed to someone who can get that quick referral and to see a craniofacial surgeon. So I think it's very multifactorial, and it's something certainly that we are trying to look into in our own studies in the greater DC area that we're currently working on.
I think it's really a national issue that is multifactorial. You're absolutely right. You are definitely right. I think one of the things that is interesting that I found was the conversations that I'd have with parents about the 2 different options, and I know your paper didn't get into that as much. It wasn't the purpose of it, but that's another whole interesting conversation, because to do the endoscopic or the surgery that then involves a helmet, that is that's a burden. Although having the open surgery is a big deal in terms of it's a bigger surgery, high risk, have blood transfusion, longer hospital stay, etc. It's a sort of, once it's done, the child goes home. it's, the parent doesn't have that responsibility of then having to manage a helmet, which is a whole other, so it's sort of like when you do jaw distraction, where, if you did jaw surgery that didn't involve distraction, it's different in terms of the parent's responsibility. So I wonder if that is presented to some of the families, especially the lower socioeconomic families, if it's just something that is something that they couldn't manage, because I remember we had those conversations with our within our team and with the families sometimes, just your paper brought up just a lot of other and that's what I really enjoy about the work that we do as a team, because the patient, I always used to talk to my surgeon about this. It's like we get our job was, let's get that child to the table, and for the surgeon, often didn't know always the whole background of what got. And that's one of the things that Dr. McCarthy, especially, or my first boss, used to say to the residents and the medical students, is that you have no idea what it takes to get a child to the table, especially for these big procedures. And what you talked about in this paper is a big part of it. It really shows the importance of the team, and how can we help these families. To Al's point, how can we help them overcome those barriers to get the care that everyone should be offered the same care. What thoughts did you have, Melanie, when you were reviewing this? And you can maybe talk about a couple of the other things that you found.
Yes. So as we are kind of talking about right now, I think the big consensus among most of the papers was that patients with lower socioeconomic status tended to show up later, and then of course tended to have the open procedure, as we're mentioning. And then patients of higher socioeconomic status presented earlier and underwent minimally invasive procedures. And I think we were also trying to understand what is the reasoning behind this? But when we looked at all the other variables that were covered, so they didn't really dive into exactly those barriers. And so some of those barriers that we're thinking of that could have been included in these studies but weren't really touched on were primary language, transportation, maybe even something even harder to quantify, but also important, is patient-provider trust. So all these different barriers to the care weren't necessarily measured in these studies, and probably because it's harder to get that data than just say, oh, what time did you get to the what age were you at the hospital, or what procedure did you get, right?
Melanie, I thought that was really interesting at the end where you talked about that one of the factors would be, I wanted to just read what you wrote, that as you said, there's a lack of exploration of other impactful variables relating to language, transport, work flexibility, and patient trust, mistrust in the healthcare field. So interesting. And I wonder, over the years, and Al, you've seen this. I mean, when I first started, way before you were born, Melanie, there was no internet, there was no information. And so, I mean, parents would come in and they, I found I didn't have any trouble with establishing trust, because they came to us, we said, yes, this is what we do, and Dr. McCarthy used to say, I would just, pat them on the shoulder and say, it's going to be okay. And, but they didn't have the ability to go and search and go get other opinions. And you just wonder, what is it? How did we evolve into this trust and mistrust? I don't know, Al, I mean, what thoughts you might have on this, but it's something that because now, parents come in, and rightly so, and they do their research challenging, well, why are you doing this procedure? And what about this? And, it's just interesting. It's interesting to me.
Yeah, I agree. And, certainly, and I've been doing this now for about 20 years, and even within that span of time, I've seen the difference that information, misinformation, limited information, all of these can play a role in patient trust. You certainly see, patients, families that come in, and they readily will acknowledge that, yes, I went on the internet and I Googled this, and I wish I hadn't because I saw all these horror stories, and you know, but I couldn't help it. I had to read, and I do think that having families that at least are somewhat informed is helpful in the general background. But I agree. I think back in the day, it was, having no information was in some ways made things simpler, because you just trusted the doctor to do the right thing and the team to do the right thing. Whereas now, everyone knows that it's not quite as black and white as that, right? There's a lot of gray areas where some people would say, well, I would do this type of procedure, I wouldn't do that one, or what have you. And so it is challenging, to navigate
Melanie,
through that.
I think it presents more of a challenge for you, and for your generation of plastic surgeons, where you have families that are going to question more, and so what are your thoughts moving forward? How do you feel like, as you go through your residency, that you are, how do you build that trust? Because I do think that that's, a factor in why some families pull back from doing surgery, or, just feel, are, because it's a big, it's a big thing for them to consent to. I always remember, as a nurse practitioner, I was able, part of my responsibility was to get consents for surgery,
Right.
and you had to do the risks, the benefits, the alternatives, and then, and again, trying to get that trust.
I think so. I think I have like two different ideas on this. So one is I think our curriculums these days do a really good job of trying to teach students the history of health in the US and how certain marginalized populations have received worse care than other communities in the US, and how this has impacted healthcare now, and stories that are passed down in families, and how people view providers now. So, and now empowered by internet, they won't necessarily just blindly accept any decision or recommendation from a doctor. They'll likely, patients who have been historically marginalized will likely double check or see what is actually the right way to go about this. So
Right.
I think being aware of that and knowing the history of it all will be one big factor in trying to make sure to be sensitive when it comes to talking about serious surgical procedures or anything that might be scary to patients. I think that will be play one factor into it. And then secondly, I also think it'll be very important to be up to date on the literature, like look at all the current recommendations and see what exactly are the barriers. So if there are studies that look at barriers, trying to understand what exactly are the barriers to care that we can help mitigate for these patients, and then making sure that they know, as you mentioned earlier, okay, so there's not always 100% chance that after you have the minimally invasive procedure, you won't need another procedure down the line. So making sure to be very clear with all the possible routes that certain decisions can have, and the implications of everything. I think just being very clear, open, and honest with your patients, and taking into mind how scary and like their background will also play a part into this.
I also think, Melanie, I'm old school enough that I do very little social media, particularly at a professional level. But I think your generation is going to have an interesting challenge in how to navigate that, because I see doctors who are even my age and my level, and certainly ones that are younger than me. I mean, they're like all over Instagram. They show their procedures, they show the results to
Mm-hmm.
me. I personally find that a little bit just not something I would do. showing your half naked patient on the operating room table and things like that. It just doesn't sit well with me. But I think that it's inevitable. That's the future. And a lot of parents will get their information about their children's conditions by social media, for better or for worse. It's not going to be, they don't read the professional journals, right? Because, they read, some Instagram, celebrity who says, oh, my son was born with this condition. This is what I did. And so I think that your generation will need to, and then there's already steps going in this direction, but, really come up with responsible and just well thought out approaches to how you're going to promote your institution, promote yourself as a provider, and share information that's appropriate with patients and families that isn't about sensationalism, trying to sell yourself necessarily, but trying to get the right information out there.
Yeah, I think that is
Definitely.
I think it's such a great point, is that, using social media to really connect with the families in a positive professional way. And, and it's interesting because there are parents who, who want to see they want to see your results, but there's a way of presenting that. And so, it's that balance. But I think that, social media is here to stay. And I think it is an important way to communicate with those who may be considering coming to you for their care. But I think you're right, Melanie. It's starting in your training is to really help the students understand where some of these families are coming from, just historically, in terms of being marginalized and their distrust, not just in terms of surgery, but just overall. And I think keeping that in mind is a really important start, to gaining that trust. But I think it also shows why, with the kind of work we do, you have to do it as a team. You need a social worker that can help with these. It can't just be the surgeon, or the other medical staff that are dealing with it. You have to, you have to take the time to understand these families. So no, I think that, what this paper, what you did really opens up, a lot of other things, a lot of other areas of that we have to think about as we provide care to these patients. So I'm really glad that that you did this, and that you're right. We are starting slowly to see more papers coming out like this. So hopefully, we'll see more than 13, soon. Because already, as I look at the journals now, as I read through to see who would I like to feature, when I see papers like this, I'm really glad, because it used to be more just focusing on the surgical technique and the medical care, but this is, we need this in order to really provide the right care. So as you finish this work, and I know you're in the middle of your training, are you thinking of doing more on this topic, or are you already in the midst of it? What else can we expect to see from you?
Yeah, so we're trying to take all the information that we've gathered from here and trying to replicate the studies that we've seen done in our institution. So at Children's National, we were like in the process of trying to understand what our site-specific data shows, and then trying to also incorporate, if possible, we're still like in the data collection phase, if possible, some of these other less talked about outcomes or variables, such as like the referral time, not just at the ages of presentation, and then perhaps if we could get maybe even personal accounts, that would be something very interesting we could add to the paper and see, like, oh, what exactly made you decide to do this procedure over this one, or why did you not come sooner, stuff like that, and understand what the barriers would be. That would be really interesting. I don't know if that's possible, but we are trying to do a site-specific study.
Al, any thoughts as the senior guy on this work?
Yeah, no, Melanie is exactly right. So we've designed the study to look at much more granular and in-depth data, here in the greater DC area, to include Maryland, DC and Virginia, to try to get a little bit more detail on the findings that Melanie, described in the systemic review paper. And we'll hopefully be able to, provide more in-depth information about why these barriers exist. And most importantly, as we stated at the end of the articles, what can we do to mitigate them? What can we do to improve them?
But I think, Melanie, the bringing up the whole idea of how, why do some families have an issue with trusting practitioners, and how can we, how can we take that barrier down? That is such an important piece of it. And, it really applies to just all areas of medicine, I think. But, I think that that's a great thing to really try to, for all, all practitioners to really be sensitive to and try to really look at. So I think that's, that's one of the things that I really pulled out of this as I was reading in your conclusions, towards the very end, when you said that, it just really, it really made me stop and think about, what are the barriers, and this is one, that we really do need to look at early on in training. You really have that sort of embedded in you as you proceed, with your training. That should be a part of your training throughout. So really good work. I'm looking forward to seeing, the next chapter of this. So, and I wanted to, for the listeners, when we repeat this paper, which really everyone should take a look at, and sort of think about that as you meet families, and especially those who seem to be struggling with trying to decide about what care their child should have. And again, it's a big decision for parents, and it's very important. This paper is really important. So paper is, and you can find it in the Cleft Palate Craniofacial Journal, OnlineFirst. June 17th is when it was posted, page 3 of the OnlineFirst. It is Socioeconomic Influence on Surgical Management and Outcomes in Patients with Craniosynostosis, a Systematic Review. And this comes from the Division of Plastic and Reconstructive Surgery at Children's National Hospital in Washington. The authors, Melanie Bakovic, who's here with me today. Thank you so much for getting up at 5:30 in the morning. You're amazing.
Thank you.
Liliana Starsiak, Spencer Bennett, Ryan McCaffrey, Esperanza Mantilla Rivas, Monica Manrique, Gary Rogers, and my good buddy, Dr. Al O. So thank you for spending time with me, and I really look forward to I look forward to seeing you, Melanie, have a bright future as a plastic surgeon. I know you'll be great, and I hope to see you at future meetings and on another podcast. I'll be looking for your next paper. Thanks so much.
Pat, thank you so much. Yeah, it's always a pleasure to see you.